Hello, my name is Brittany or Rowan Rivers, and today I'm going to be talking about neurodivergence in the trans community. I originally did this presentation for a local organization that supports professionals that work with the trans community in education and standards of care and ways that we can better serve the community. So I want to start off with a land acknowledgement. I acknowledge at the time, and I am currently on the ancestral homelands of the Timucua or Patano, Miccosukee, Seminole, and Muskogee peoples. Through various means, these communities were killed, died by disease introduced by colonizers, enslaved, or forced to flee south or west to survive. In Timucua society, two-spirit individuals held vital community roles, often serving as priests and tending to those who had just given birth or were menstruating, caring for the sick, and preparing the dead for burial. I acknowledge anti-trans and ableist rhetoric, laws, and violence as aspects of ongoing colonial violence in our society. I acknowledge the various ways that Indigenous communities continue to fight for their sovereignty, lifeways, and sacred landed relations. I will continue to pursue avenues to support Indigenous communities with decolonizing efforts. So, a little bit about me. I received my degree in political science and counseling from the University of Florida. Been working as a mental health counselor since 2015. I've worked at various agencies and levels of care, and I'm currently in private practice. Over the past few years, I've been studying neurodivergent affirming care practices. And most of my clients live at the intersection of being both queer and neurodivergent. In terms of my positionality, I am white, chronically ill, have growing disability, master's level educated, middle class, a settler, and I have spent most of my life, lived all of my life in the Southeast, where who I am has been questioned and challenged and unsupported by the main institutions. I am both genderqueer and neurocomplex. I actively work to decolonize my practice by building lineage and landed relations. I attend trainings and support organizations that support lived experience, prioritizing lived experience and learning from BIPOC and Indigenous teachers. So here are some terms to start with. So this image shows the neurodivergent umbrella. So a lot of times people think that and you might have expected when you are reading this or looking into joining this talk, that neurodivergent means autism or maybe ADHD. There's actually many types of neurodivergence, pretty much everything that's in the DSM or our diagnosis manual for psychology and mental health. Um, and what that means is neurodivergence, a mind that functions in ways that diverge from dominant society and the standards of quote unquote normal or neuronormativity. So, outside the boundaries of this culturally constructed idea of what is normal. So, autism could be a type of neurodivergence, but there are many other types. Now, with that being said, as I go through this presentation, most of the information will be about autism because when you search neurodivergence, that is what, or when I search neurodivergence, that is pretty much what came up. Sometimes ADHD, but mostly looking at autistic people. Another term that gets sort of confused is neurodiversity versus neurodivergence. So, neurodiversity really includes everyone. It's our biological reality. It is just another type of diversity. We have different brains and nervous systems. Um, we're all unique in that way. And that is uh, something that we're all part of. So everyone is part of the diversity of brains that we have or neurotypes that we have. Now, neurotypical is sort of on the other end of neurodivergence. So neurotypical are people that have a neurocognitive functioning style that falls within the dominant standards of normal. So living, acting, and experiencing the world in a way that consistently falls within those boundaries of neuronormativity. And then I mentioned neurotype is that there are different we have different neurotypes. There's variations in human cognitions and we have different neurotypes. So autism might be a particular neurotype. Neurocomplex then is when um, and of course, that neurotype would also be varied if there were other types of neurodivergence that the person is carrying. And that leads into neurocomplex, where someone is navigating multiple forms of neurodivergence and that there's increased complexity in terms of their cognition, sensory receptivity, attention, things like that. Neuroqueer is queering, or if you're not familiar with that term, subverting, defying, disrupting, liberating oneself from both neuronormativity and heteronormativity, and approaching neurodivergence as a form of queerness. Neuroexpansive speaks to some of the issues here we have with these terms when this whole idea of neurodivergent is sort of, okay, well, what are you diverging from? And looking at that overlap between those ideas of normal and how that actually is code for whiteness. Um, and that this term actually, like neurodivergent, doesn't actually apply to Black people because these whole concepts were never constructed or built with the acknowledgement or understanding of Black people. And so it doesn't apply to them. So neuroexpansive is a term specifically for Black disabled people. Gender vague, and I've also heard the term gender more so from an autistic perspective and a unique gender experience, but gender vague is specifically a neurodivergent experience of trans and gender identity, where gender mostly impacts the lives of people when it is projected on them or when other people's assumptions are projected on them, but has little intrinsic meaning. So there are many more terms, but these are just a few that I thought might be helpful. This is a legend. So as you go through this, the slides are text heavy, and I did that because I just had so much information and I wanted to share, and also just where I was at with my own capacity. This is how the presentation turned out. When I presented previously, I was asked what different letters meant, and so I thought it would be helpful to have a legend. So if you're wondering what letters mean, these are some definitions. So an invitation here, and some of the things we'll be talking about, is shifting paradigms. So, paradigm is a set of fundamental assumptions or principles or mindset or sort of a frame of reference that shapes the way we think and talk about a subject. It shapes how we interpret information and determines even the questions we ask ourselves and others, the lens that we see reality through. Whereas shift is an opportunity to redefine and recalibrate, reinterpret, rethink those paradigms. So, one of the things we're being invited into with this community is shifting from a pathology paradigm to a neurodiversity paradigm. So, from a pathology paradigm, if we're looking at autism, we might see a medical disorder, conditions, deficits, these assumptions that there is one right, normal, healthy way for brains and minds to be, and that minds must fall in this narrow range of normal. And if they don't, then there's something wrong with the person. So this unfortunately results in autistic people being stigmatized, dehumanized, abused, harmed, and traumatized by both professionals and their families. using language of symptoms, treatment, epidemic, curing, and really privileging certain ways of thinking and being in the world while marginalizing others. And within the pathology paradigm, this is not even acknowledged, really, this whole concept of marginalization. When we're shifting into the neurodiversity paradigm, we can see that certain ways of being in the world are really privileged. Um, so neurodiversity invites us to embrace the diversity of minds and that is natural and healthy and valuable, and that there's an infinite variation of neurocognitive functioning, diversity in how we think, perceive, know, and develop, how our minds process information and interact with the world, and that our minds is an embodied experience, and there's no normal or right style of mind. This can support neurodivergent individuals to challenge that internalized oppression or ableism and to lead to better self-compassion, understanding, and well-being, because it's acknowledging this diversity versus pathologizing certain people's minds and way of being in the world. So again, we're going to be going into autism a little bit. So this is the DSM criteria for autism, and I just wanted to highlight a couple things in how we're framing autism. Deficits, inflexible, restricted, impairments, limited. So not painting such a great picture of the autistic experience. And here we have another definition of autism from a autistic researcher and advocate. So we've already looked at seen this piece of it's a neurotype. It's a hereditary neurological identity or neurotype of neuronal hypersensitivity, attention filtering style called monotropism, a sensory processing system first, and a verbal processing system second. So monotropism is a tendency for interest to really pull autistic people more strongly. I like this sentence: energy is our first language, words are our second. So then there's a note that having these kinds of neurological differences is disabling in society. The DSM criteria for autism is such a messy mix of innate neurodivergent traits and symptoms of autistic trauma that an autistic person without trauma may not even fit criteria for a diagnosis. And that is something that we'll be bringing up later, and also something that comes up in my trainings is there are these things that are said about autism, and we don't in some ways know, is that fully an autistic trait or is that a symptom of the trauma? So, for example, with interoceptive awareness, so that is our awareness of internal cues. Am I hungry? Am I thirsty? Do I have to go to the bathroom? And that can show up in different ways, but those are just some examples. And there is sort of this idea that autistic people have this hyposensitivity. They're just not as in tune with those things. And one of the things some of my teachers have said is, well, is that actually the case? Or is it that you've just been taught your whole life to ignore your needs? And so that attunement has been really disrupted. So it is an important consideration that it is traumatic for many neurodivergent people navigating this world. And then this is an important point. Any attempt to cure, treat, or eradicate autism is a form of oppression called ableism. No therapy can make an autistic person less autistic. However, there are many things that we can do to lessen the distress of living with this disability. So this is also a point that we will get into with some of the research. But I thought this was an interesting juxtaposition to really look at, okay, what's the DSM and this pathology paradigm versus just describing these pieces of the autistic experience, how that lands differently and how that might land differently with autistic people. So this is another piece I wanted to bring up, are some of our issues with underdiagnosis. So the original presentation that I watched about some of the underdiagnosis in women and girls, at that time, these numbers were more off. I think it was 1 in 86 uh, for every um, sort of one boy, out of every one girl, there was 86 boys or something like that. So it's like those numbers have decreased in terms of the discrepancy. Hape's hypothesis was noted that there are a lot more girls, like these numbers are a lot closer. And of course, this is talk using binary language, and the presenters did say that part of the issue with this is the binary discussion and research, and that is a limitation. So for this slide, I'll use that. But now it's for every one to 36. So there's it's 4 times more common in boys now. So we have reduced that gap, but there are still issues in terms of underdiagnosis in this population. And as I was communicating this to professionals that are working primarily in gender affirming care, I think this is an important piece to sort of hold when you're looking at the research, when you're looking at statistics, when you're engaging with your patients or clients, that this may be an issue that people are coming in that would be autistic or that are autistic, but they have not been diagnosed, and how that might show up a little bit differently. So, unfortunately, as they brought up, is that this is sort of self-reinforcing, is that the research is largely based on males. So, and this is white cisgender boys. And so that research was utilized to develop norms and assessments. And so it largely describes autism in males, and again, white males. Uh, with girls and women, there's a subtler manifestation of some of the social and communication difficulties, and they are less likely to be identified even when symptoms are equally as severe, unless there are some serious behavioral concerns or their mental health significantly declines, such as developing an eating disorder or severe depression. And so this is something that I've also picked up on, is that there is a high prevalence of autistic women in eating disorder treatment. And in my eating disorder treatment, that is not often discussed. You have to sort of go out of your way for more specialized training. In my experience, I did not really hear of it until I was specifically attending trainings that talked about autistic people and autistic women in uh, with eating disorders. And then the other piece with severe depression is that some women are not being diagnosed until they're going through something like autistic burnout, where they have been struggling and engaging in masking, which we'll talk about in a moment, for many years, and then go into burnout and have significant depression, and it can be disabling. So masking, blending, acting or pretending, mimicking, camouflaging, scripting, these are some words for how autistic people try to present themselves as neurotypical. The same percentage of men engage in this practice, but women mask more across more situations and more of the time. And so, what this looks like is that they are less likely to be diagnosed because of some of these because they're so effective at these strategies, but um, it is still causing a lot of harm behind the scenes. So it leads to depression, suicide, struggling to function, sensory overload, a loss of skills that sometimes may not return, unfortunately, chronic exhaustion, meltdowns, loss of speech. So some of the things I've heard when I have clients that are courageous enough to bring this up with their psychiatrists. One of the experiences recently, oh, you've been watching a lot of TikTok videos, or you've been watching a lot of social media, so you just think you have this diagnosis. Here's the thing, when our institutions have not caught up with the needs of um, the community is crowdsourcing information, and that has been a long history in the autistic and neurodivergent communities, is going to online to find friends, community support, ideas, resources. How do we support each other? And so it is really problematic to speak from a professional, privileged, institutional space and diminish or demean the importance of those avenues. And yes, that doesn't mean that people are always correct. And there may be things that are off, there may be misinformation, but what it really is it's an expression of how we really aren't where we need to be yet in some ways, and either way, that this is where innovation is happening. This is where lived experience is honored and supported, and people are building community. So this is important to be curious about. I think at least some of the other dismissals. Oh, you're too social. You carried on a conversation. Looked me in the eye. You understand humor. It's just social anxiety. So these are some common ways that women and girls are dismissed when they do bring up concerns about autism. And then we have another group. I'm sure we could do this under diagnosis piece on many populations, but here went a little bit also into Black children. So Black parents seeking an autism diagnosis for their child on average takes about 3 years from when they bring it up to a doctor to when the diagnosis happens. And this is very unfortunate because early intervention has been proven to be critical in terms of cognitive and language skills. Unfortunately, often primary care physicians are dismissive, blaming disruptive behaviors on poor parenting with harmful stereotypes, saying people are playing the system for free services. And so then we run into this other issue where these assessments were not developed with this population in mind or normed on this population. So many of these evaluations were developed with white middle class children. And so they are less accurate. And these children are having to endure more evaluations and often getting misdiagnosed. And I think it's important also to acknowledge that Black people have been more likely to be misdiagnosed, criminalized, or killed rather than treated with care. So, again, I wanted to bring this up to just highlight that this is an important piece when we're working with this population, with the autistic community, neurodivergent community, is that there may be quite a bit of underdiagnosis. And then when we're looking at the intersection of gender, when we're looking at the intersection of race, that there's even more stereotypes and harm that is being done as well to invalidate people's experiences. So these are things we need to be mindful of with our patients. So we've already started to talk about some of the research limitations. Um, with some of the stuff I just talked about, there's this other piece, which I kind of mentioned before, is that looking at these impacts of minority stress and the nervous system impacts um, that have been caused by a lack of, so if these people are going like longer periods of time without getting diagnosis, without getting the supports and accommodations, how does that play out in their nervous systems and how does that show up in what we're seeing in the research? So I think that is an important consideration. How can we create more inclusive spaces and across ethno-racial identities and leadership and the perspectives represented? So one of the big pieces that I think shows up is in the history, sort of the progression of research is that a lot of the stuff from the past, and this is somewhat shifting and being challenged by the autistic community, and hopefully more research will be focusing on the lived experience perspective of autistic people and having them as active members of the research process, is that a lot of the old stuff was based on observations, and that is where we get things like ABA being the gold standard of treatment. So applied behavioral analysis is and in my training I was told, this is what they do, this is what they offer, and this is what works for autistic people. However, there's autistic people in the community that are coming out and saying that this gold standard treatment leads to feelings of shame, anxiety, internalized stigma, post-traumatic stress disorder. People are calling this violence, they're calling it a child abuse. Um, because it's based on these observations of what neurotypical think autistic people should do or should be, or what would be health and healing for them, rather than what autistic people want. So it is more focused on this concept of a cure or fix or stopping behaviors, rather than trying to really understand and support autistic people where they're at. Um, I think that can be a big issue that we need to be mindful of when we're looking at assessments, when we're looking at treatments. And were autistic people part of the development of that? What do autistic people say about it? What's the impact on them? That's really important in terms of a treatment consideration. So, yeah, so we will talk a little bit more about this other stuff coming up. So, rates of autism in the trans community. So there's a higher percentage of autistic people who are trans, and there's a higher percentage of autism in the trans community. I like this way of framing it. If you're providing services to autistic people, you can assume that somewhere between 5 to 10% of your patients may be trans. Whereas if you're providing services for trans people, you may assume that somewhere between 7 to 20% are autistic. So this is actually, there's one study that I looked at this particular, said that there's no difference in autistic traits in individuals who were assigned male at birth and cis men. However, about 2 times higher autistic traits in those who were assigned female at birth versus cisgender women. So really that population is where it was noted in that study, the difference is showing up, and that this is an often understudied group, because as we already mentioned, if you're just doing those binary terms, you're maybe missing this group, but then also this group is 3 times as likely to identify as non-binary. So even if you were looking at it from a trans perspective, if you're not opening the door for looking at the non-binary community, you might miss this group as well. So why is this? Well, I'm going to note these things, but I'm also going to say that this is actually something that is critiqued. A lot of the research, unfortunately, is focusing on trying to understand this connection and doing it in a harmful and invalidating way. And I will note that in a moment, but just some of the things I have listed here, these are speculations. So it's not something that an answer is known to this for this question. But potentially, in terms of looking at the differences with those assigned male at birth, is that their autistic traits may align more closely with traditional masculine roles, and there may be a less acceptance of gender nonconformity in that community. So maybe that's why it's not showing up as much. Gender variance is not showing up as much there. Um, this one, like some of the things I will say, I don't know if this is just a stereotype discrimination or this is a real thing, but they say a lower capacity for mentalization may contribute to less defined gender constancy. Like for autistic people, they're saying they have less of a capacity to hold a mental concept. I find that to be questionable. I don't really know. So, but that it was something that was listed. Um, so if you are autistic, then you might be sort of on the outside of the social groups, maybe on, the edge or the outskirts and kind of on the outside looking in. And so because of that experience, it may give people more space or capacity or resilience to critique what they're seeing when they're looking in at those social norms and binary constructs. They may not make as much sense. One of the things in terms of accessibility to care is that binary transition may be too difficult. So, due to different pieces with the neurodivergent experience, depending on the person that really fully holding or going towards a binary concept of gender may be too much. And so that may be more of why non binary feels like a more comfortable zone for some people. Again, speculation. But here's another thing is that it's theorized that the same numbers of gender variance actually exist amongst neurotypicals, but possibly they are more susceptible to those cultural pressures, or again, there's maybe less opportunity to examine that stuff because they're on the inside. So, just a couple of pieces that were pointed out. So, again, there's a lot of stuff about the validity of this intersection. So my hope is that the people that were doing this research were like, people are questioning this, so let's get some numbers on it. Let's look into it to really support the community, because there's the conversation around this stuff is very questionable. Of like, why don't we just believe people? Why are we debating what someone is saying their experience and their identity is? Um, So we'll get into more of that. But what they found is that it is valid. Gender identity is incorporated into self concept outside of conscious awareness and control, and developmental continuity of gender diverse feelings in both autistic and non autistic trans clients. Research is showing no difference in implicit gender. This quote unquote overoccurrence exists in young people and continues into adulthood. It occurs across countries and cultures. Um, Autistic trans young people are no more likely to experience shifts in their gender related medical requests. Um, Autistic trans people show neurophenotypes consistent with cisgender autistic people. They're seeing this, early signs uh, at young ages. That is consistent. There's no published study that shows that there's a higher experience of regret or detransition. And then one of the things this gets into some of the discrimination that this is not caused by minority stress. So it is an inherent. It's there beyond that. So some people that are challenging this say, oh, it's just related to minority stress. Well, it's not. So we have data that shows that this is valid. Um, so I also wanted to talk a little bit, throw in this piece about the models of disability. Some of this, in a way, I've already been talking about. So with the pathology paradigm, we are thinking about the medical model here, where disability is an impairment, it's located in the individual, and that it is different from normal and needs to be cured or fixed, something like that. What's most common I've seen is the social model, where society is set up to meet the needs of certain people, but not others, and it privileges or enables some and disables others. And someone is disabled to the degree that their participation isn't properly enabled and that accommodations enable full access and participation. The identity model is more so inviting disability in as part of someone's intersectional identity. So you've already started hearing me say this when I'm saying an autistic person versus a person with autism. And the things that I've read from autistic people about this is that autism is so fully integrated in who someone is. It is their operating system, it is their brain, that how their brain is structured or neurocognitive functioning. So it is not something that can be separated out. So it is an autistic person versus a person who has some um, disorder or something like that. Then the holistic model recognizes the intersection of disability and other parts of a person's identity. So taking that a step further and really creating more space to look at the fullness and wholeness of those intersecting identities. And here is a definition of ableism. A system of assigning value to people's bodies and minds based on socially constructed ideas of normalcy, productivity, desirability, intelligence, excellence, and fitness. These constructed ideas are deeply rooted in eugenics, anti Blackness, misogyny, colonialism, imperialism, and capitalism. This systemic oppression that leads to people and society determining people's value based on their culture, age, language, appearance, religion, birth, or living place, health, wellness, and or their ability to satisfactorily reproduce, produce, excel, and behave. You do not have to be disabled to experience ableism. So that's leading into what does some forms of discrimination look like? So, one of the biggest things that was coming up that I noticed was how the research and the sort of social challenge to this overlap was really trying to say that someone being trans or having gender variance was a symptom of being autistic. And that if the autism was treated or a mental health condition was treated or cured, that the person would no longer be trans. And the attempt to search and find a reason why there is this overlap and to treat or cure or fix it is what would be considered epistemological violence. So, where a researcher's particular interpretation of data about individuals and groups is presented as this is just the unquestionable facts, even though there are other equally possible interpretations of data, and it constructs different identities of groups as inferior, and it's problematic and can lead to negative consequences. So, seeing a client's gender as inauthentic because of an assumed mental deficiency. So, these are, I found that that was coming up a lot. And there's sort of this assumption that our cultural ideals of gender are natural and normal. And so that plays out when we as a society are looking at autistic people and challenging, like, oh, well, why is there so much gender variance in this community? If we were not applying discriminatory views, we would just say, oh, yeah, this is how it is for autistic people. Um, so these stereotypes and misinformation about autistic people leads to views like that they lack capacity, they lack the capability to identify their gender, understand their gender, and that this diversity is more of an obsession than an identity. Um, there's also this a lot of times this comes up with the communication styles instead of saying like, oh, well, um, so one of the things I've seen brought up is the double empathy problem, which is usually autistic people are framed as not having good communication or social skills, and that they need to work on those skills or they need to adapt to other people, to neurotypical people. Whereas the double empathy problem frames it as neurodivergent or autistic people and neurotypical people or non-autistic people have trouble communicating with each other. Because if you look at autistic people, they don't have issues communicating with other autistic people. It's more of that wires get crossed and who is made responsible for um, merging that gap. And often that is put on autistic people. So you don't really have neurotypical people are not really acknowledging their empathy deficits and their poor communication skills. Another thing that was pointed out was this concept of theory of mind, which is basically saying that autistic people, I mean, I don't know. This was a big concept, but from what I gathered, it was that they don't have a concept, autistic people don't have a concept of their own mind or other people's minds. And even though this was disproven, that this is still carried on and it's showing up in this way. And I think it's applies to this situation where um, these groups and laws and or people are sort of saying that, oh, well, they can't know their own gender when that is not, that was disproven. So a lot of the stuff that people are bringing up is more so discrimination. One of the things I already started to talk about a little bit was this experience of chronic health and mental health issues. So, I talked a little bit about the trauma of navigating the world as an autistic person and how that can show up as traits that are ascribed to autism when they're really an expression of trauma. But if you think about it, um, if someone is also living at the intersection of other marginalized identities and facing things like racism, sexism, how that plays out in their nervous system. So these experiences of discrimination and the overlap in this community with so many chronic health conditions. Um, so this is showing up in people's medical health as well. And then this is a question: is it that this is just sort of a genetic overlap, a predisposition, or is it associated with and the sensitivity, or is it associated just as much due to, if not more due to that high stress load of navigating discrimination and oppression and poor access to responsive care. Decolonizing perspectives. So this is also something that I wanted to bring up. So colonization prioritizes certain bodies, minds, and ways of living while marginalizing others. These ideologies not only justify colonial practices, but also shape societal norms and expectations about health, ability, and productivity. Settler colonialism systematically marginalizes Indigenous, Black, and disabled populations, treating any deviation from colonial norms as a deficiency to be corrected or eradicated. Settler colonialism not only oppress but constructs disability through its persistent efforts to homogenize and control bodies that differ from the settler norm. So, whatever you think about colonialism, and some people are think that it just happened in the past when it actually is still playing out today. As I mentioned, you may have caught it. I'm a settler. Like settler colonialism is still playing out in the United States and other regions of the world. We're actively engaging in colonial practices, and many of our institutions and social structures are built on colonialism because that is our history. It's not just this political and economic force, it's also this cultural and intellectual concept of how we are supposed to, rigid standards of how we're supposed to behave and be in the world. And so certain ways of being are privileged over others, certain ways of being are pathologized, certain ways of being are actually disabled here because of how society and the systems and structures of our society, government, economy uh, interact with an individual's or group's nervous systems and bodies. So I think this is also another perspective to bring into play, and I think is extremely important in looking at these intersections of how that is playing out with this community and everything else really in our society. So it is really important that we work to prioritize diverse perspectives here because what is being noted is that most of the scholarship here is based on white people from the global north. Um, the scholarship and even the concept of neurodiversity is really coming from this uh, population where there are many other ways of conceptualizing and working with and understanding neurodivergence. And unfortunately, often intersectional experiences of Black and Brown individuals are being erased, and Southern and Indigenous epistemologies are being marginalized when, again, there are so many things that um, we could learn and grow in from inviting in these other perspectives. And so it is also really important. This was noted in some of the research, particularly to focus on that the pathologization and dehumanization of racialized individuals, and that material structures are oppressive and violent toward racialized neurodivergent individuals. So, gender affirming care and affirming autism services are disproportionately serve white and economically privileged individuals. So, many others in this community are in carceral systems, disabled, and unhoused. So, living at that intersection that it can be um, much more violent and lethal and oppressive. And I think that's an important consideration when with what a client may be coming in with when they're seeking care, and how we as providers maybe need to be working more in our communities and in research and treatment options. So here's another way some of the discrimination is playing out in terms of the political targeting. So laws relating to gender affirming care are already, so the people that are targeting the trans community, maybe they were looking through some things and they found, oh yeah, there's some overlaps here. So they are trying to, or it seems, uh, targeting it from this angle. So, suggesting that care should be withheld from autistic people, requiring doctors to determine whether a patient seeking care is autistic, and some of them are require or wanting to require that doctors are making sure that mental health issues and autism or ADHD are resolved prior to treatment. Um, and that questioning whether trans youth with mental health issues should have access to care, again, with the assumptions that autistic people are incapable of making decisions. And they're doing some stuff around doctors and liability. And if a doctor has to check the box that a patient doesn't have X, Y, or Z, or that they have to resolve it, or that these mental health issues are causing causing dysphoria. Um, and some of the stuff with the providers is sort of putting them in a tricky position of like threatening liability, or like sort of liability issues could be threatened by making them have to make these assessments. So how this is playing out, we have the example of Caden Clark. A few years ago, a young trans man in Arizona was killed by police responding to a mental health crisis after Asperger's diagnosis was used to deny access to transition-related care. So if you're not familiar with that, I believe Asperger's is still used in other countries, but in the United States, it was sort of incorporated into the autistic spectrum disorder. So after receiving this autism diagnosis, a mental health therapist would not approve hormones until after his disease was cured, meaning he would never be eligible for transition because you can't cure autism. So following numerous suicide attempts related to gender dysphoria, he was killed by police after a suicide call. So this puts patients in a very vulnerable position. And again, is another way that our clients and patients are being targeted. Um, these are from a couple of cases, or from a case um, with some of these ideas being brought up. So these are some of the ways that this intersection is being used to try to deny care. So, children on the autistic spectrum are more likely to face difficulties fitting in with their same-sex peers, which makes a transgender identity obviously appealing as both an explanation and solution. This is absurd. Um, and so the expert challenging said there's a considerable overlap here. That does not mean that assuming a trans identity is a workaround for difficulty fitting in with peers. There's no data to support this. Uh, and there's no data to support the claim that elevated suicide risk affects autism. So reflects autism. So we don't have data that shows that people are using this as a reframe, although that seems to be related to a different point. But um, we don't have data that shows that kids are using this as a workaround to not fitting in. Requiring that a trans patient resolve all co-occurring conditions, many of which are chronic, with no reasonable expectation that they will be resolved. So prior to receiving a gender affirming care is not possible or ethical. Should be reasonable. So uh, such conditions should be well controlled and not impair the patient's ability to make informed decisions. But for many of these things, like autism, a complete resolution would be impossible. And so this is basically a denial of care. Suggesting that autism is a cause of gender dysphoria is not supported by any evidence. There's no research that suggests that the treatment of autism alleviates symptoms of gender dysphoria. Thus, any relationship between the two conditions is irrelevant for the purpose of determining what treatment is effective for gender dysphoria. So here we have some professionals, experts in the field that were brought into a case to challenge some of the misinformation that was being used to um, interfere with individuals' access to care. So this is another area where some of the things have been noted that the people that are challenging access to gender affirming care may be looking at the WPATH standards, which, if you're not familiar with that, they create the standards for gender affirming care. What the WPATH actually did, so that's noted in this first point, intersectional statements were designed to encourage greater attention to accommodations with neurodivergent people may benefit from and navigating gender discernment and care. They're not designed to restrict access to care. So there are some notes in the standards, particularly about neurodivergence and autism, and it's more so being attentive and supportive and thinking about accommodations to support and help clients. But some of these entities took that to say, oh, well, we actually need to deny care here, restrict care. Um, what they're kind of doing is putting on this guise of like, oh, these are, sensitive, vulnerable children, and we just need to protect them from themselves. They don't know what they're doing. It's a very paternalistic thing. And at the end of the day, it's sort of this, I don't know, maybe a wolf in sheep's clothing thing. Like, oh, yeah, I'm here to help you. I care so much about you. But at the end of the day, what they're doing is very invalidating, and it is discriminatory, and it's denying care, restricting care. And what's scary about this is um, some of this is going into, so one of the things I wanted to mention about this is that sort of what they're doing is this, like I mentioned, this sort of, I don't know another way to say it, like a wolf in sheep's clothing of like, we're going to um, take care, it's sort of very paternalistic, like we're going to take care of you, these sensitive, um, vulnerable youth, like we need to intervene to protect them. So I mentioned that, but the piece that is a little bit more jarring as well is that they're actually talking about this into young adulthood. So one of the ways that some people talk about these bans is sort of thinking about the progression of them, like who can they target first as they work their way towards an outright ban of things, and that maybe youth, and then certain youth, and then even certain young adults, that like saying that they need more time to figure themselves out. They don't really know who they are. They don't know what's going on. So this is very dangerous territory that some of this stuff is going into. And it's really playing off of that discrimination, that we can't trust these people to make their own decisions. We can't trust them to know who they are or what they need, and really pathologizing them. So we've already talked about some of the barriers to care, but these are a little bit more. So one of the things, when this that came out in a study that looked at individuals who are living at this intersection, is they actually noted that transphobia was one of the biggest things for them in medical settings, which again you would expect, but maybe some even saying that that was more so what they had experienced than not as much ableism related to their neurodivergence. Autistic individuals have more difficulty finding providers that are knowledgeable, or providers that are not resistant to really tailoring care to their needs. Obviously, there's more pathologizing in this community. Um, with some people even choosing to hide their autistic traits to like avoid that medical diagnosis until after transition. Uh, that barrier that we talked about with the double empathy problem of sort of a discrepancy between the patient and the provider. And one of the things to really think about again in this barrier is who is going to step in to bridge that gap. And providers really have an opportunity to step in and support their patients here by learning new skills with trainings and things. Um, so the provider's knowledge and bias and willingness to adapt. Um, so yeah, some of those I've already talked about. Is a big barrier. Again, is this misconception about what it means to be trans and autistic, and how that can really impact people's, or this assumption, this misconception assumption that that can impact people's ability to understand their gender and make their own decisions about their bodies. One of the things that was listed by the Autistic Self-Advocacy Network is that this misconception may lead to denying access to care, subjecting individuals to normalization treatments that are aimed at suppressing their gender, or placing them in guardianship or institutional settings to restrict their decision-making power. Or some providers insisting that they need the consent of a caregiver to offer medical care simply because the individual is autistic. So there can be some very significant barriers and discrimination here. So, inclusive care, these were some of the things that were listed in the research that I saw regarding creating autistic care. One of the biggest things, like I mentioned before, is actually involving autistic people or neurodivergent people in what you're doing. Um, Getting training from them, working, consulting, supervision, uh, regarding how to offer care and what changes need to be made, and adjusting your practice that way. Um, so that's one of there's some other good things too about like thinking about diverse perspective, like different perspectives from people with different, from people of color and different races and backgrounds and ethnicities, countries, cultural contexts. Like, how do we invite more people to the table when we are thinking about care? So there was also a couple studies that I looked at on some considerations for youth. Um, Again, this was highlighted that individuals should not be precluded from gender-related medical services, and to also be more open-minded. That there are more variations are more common. It may not be gender presentations may not be what you expect. And so because of that, sometimes unfortunately that plays into people questioning these kids. When it's that there's actually more variations and diversity. So many youth do have persistent gender signs, though, feelings and experiences of another gender, and should not be excluded. But there's this piece of youth may have some confusion regarding how to express their gender. And so there may not be as many outward signs or the signs that we expect. So that is important to sort of think about your biases around this. And there may be more need to for more attention on autism and thinking about the impacts on relationships and the transition to adulthood, emotional supports, and things like that. There was some discussion about communication. And so, as I've mentioned already, there can be some communication differences. And so, that is where some of that consideration for more accommodations, taking your time, pacing things to really give space to um, understand where the youth is coming from and what they want, what they need, what would feel supportive for them. Some individuals also may struggle to recognize or understand their gender concerns until later in development. So, some of this stuff may come into more awareness later on. Um, also, this extending off what we already talked about is that some individuals may not embody this sort of binary transgender presentation. And so they may not really work to present in a different gender, and that doesn't mean that they're not valid. Um, and so there may not be, again, what you would expect in terms of dress or concern about name, things like that. And so they talked about the importance of an overlap of treatment and assessment. Um, and again, I don't know if this is, again, part of the discrimination stuff, or, some of this stuff is questionable here. Um, but that just taking the time and really trying to offer collaborative care and support, so you have the input of, um, ideally, you're having a provider that is trained in both areas, but even if you're not able to have that, to have collaborative care where you're getting that input from the autistic affirming perspective and this gender affirming care perspective as well. They recommended or talked about the importance of really working with this concurrently, and how that can help support the youth to be able to communicate and what they need, and um, to be able to, um, yeah, again, I think it's like very tricky here, because you want to give people space and accommodations and support and pacing and all of those things, and really want to be mindful that this should not be um, a reason to deny people care, and to hold that line. So, some of the issues that um, I saw brought up, again, I don't know if this is discrimination, if this is a thing. So I'm just putting out there the things that I saw and some of that brought up in the studies. But they talked about this issue with flexibility of thinking, and how that might show up with an individual. So they may be that they believe that if they are gay or lesbian, then that means they must be a different gender. Um, there may be sort of a limited concept or understanding of that gender can be a spectrum, and that there's variations and can be fluid. And so one of the things they did talk about is that if you find that someone is a youth is sort of holding this kind of rigid view of gender, that if they are shown examples of, how there can be some more fluidity, or in one particular study, they talked about having groups and having individuals come that were representing a variety of gender expressions and identities, and that can help give youth a model for finding themselves, of like, oh, actually, and sometimes that may result in less of a need for medical care. Maybe it's like just dressing differently. Maybe it's doing some medical interventions and not others. And maybe that is enough if they find that they can be, um, more of a mass, they can do some more exploration in terms of presenting in masculinity or femininity, and some flexibility there. So that's something that they did talk about. Um, So there's kind of different perspectives that I saw with the youth articles. They did say, because the prevalence is so high, that if you're having a kid come in for gender affirming care, that you should go ahead and refer them to an autism specialist for assessment. But then in other areas of other research studies, they actually recommended not doing that because it's very expensive and hard to access assessments, and there may be issues with misdiagnosis, and that may be very stressful and difficult. Um, and that can just delay care. I can see you arguing both ways. It depends. I think it kind of depends on, do you have good people to refer to? Are you in an environment, like if you're one of these states where they're talking about limiting access to autistic people, that might be pretty questionable to refer somebody for diagnosis. Um, because obviously some stated concerns we've already talked about, where some people, just to protect themselves, are delaying getting a diagnosis because of the potential implications and discriminations. um, Another thing I wanted to note is this issue with treatment compliance. So whether we're talking about youth, whether we're talking about adults, is that different types of, like, seeking medical care can be difficult for various reasons. One level may be different sensitivities, different sensory profiles. Um, the other thing may be sort of executive functioning, following through with certain things, keeping track of certain things, and if the medical expectations, they may or may not be accessible to people, even if some they've talked about in some of the research is that maybe people will not even go for certain medical things because they're just like, that's too much, with all of the things they're having to navigate. And so particularly they noted with youth is making sure that they have a good support team to help them to follow through with their medical treatment and appointments. Um, so I guess going back to that piece as well, this is another one to sort of consider in terms of accommodations, is realistic expectations of what medical care can offer and a plan for medical care. So one of the things they talked about with youth is that they may have this idea in their head of like, oh, if I do X medical treatment, that's automatically going to make um, this happen for me in terms of my gender transition. And so that is another really important piece, is education of like, this is realistically what you can expect from this medical intervention, because that can be very hurtful if and challenging if a youth is expecting something and that's not going to happen. So like, what is going to happen? And then also part of that is, again, that the plan. So what accommodations and supports do they need? Making sure that they know what the plan is, and that they have the supports to be successful with that. So I've already started talking about some clinical considerations. These are some other things to sort of consider, is that with this community, there are more mental health challenges. There is a more increased rates of suicide. And part of that is because of the discrimination, the minority stress, the chronic invalidation. Um, Some of the things that you might work with is challenging some of the internalized negative biases and ableism that individuals might have from these negative social messages, and frustrations with being made to feel that there's something inherently wrong with them, feeling misunderstood by normative culture and stigma. One of the things I thought was interesting is some felt less connected to their racial ethnic identities as a result of autism due to clashes between their stigmatized identities and perceived cultural expectations. So, um, feeling as if they're not human because of how other people used metaphors to describe them, that like they were computers. Um, Higher rates of unmet healthcare needs, being refused care. That was something that popped up, that refused services by medical providers that was not related to insurance denials. Um, the process of coming into understanding of how their gender might be different from neurotypicals, and how important it is to read and connect with others with similar identities. Um, and finding that balance between empowering people to live authentically while also assessing for safety in different contexts. So, um, again, this is where it's mentioned that creating space to identify as autistic without having to go through a formal evaluation process, that was something that was brought up again because it is so hard to get to access that care sometimes. And yeah, there's a lot there. So, again, recommendations, we already looked at some of those, but one of the things is really doing your homework to understand autism, understand what might be more supportive, empowering uh, individuals to understand and embrace their differences, prioritizing autonomy, understanding needs. I think a lot of the things that I think about is unlearning how people have been taught to ignore and invalidate themselves, and to get to know themselves of like, what do I actually need? What actually works for me? What actually feels good? To even have a sense of like, what doesn't feel good? What are some themes and patterns, and sort of collecting data almost, which can be quite a tricky process because again, there has been so much invalidation and so much of this push to disconnect with the self. And so that's a lot of the piece that I think is important, and also empowering patients, adequately training providers, continuing to increase accessibility to healthcare, reduce discrimination. Um, so yeah, uh, here's a couple more things to sort of think about: validating experiences, affirming language, being respectful. I think like also this piece is interesting, like sort of normalizing this process that I've talked about, like the impacts of discrimination and bullying and how that has pulled away from an individual's, because some people will get judgmental of themselves. Why don't I know this yet? Or why haven't I figured this out? And to sort of normalize and contextualize like how much oppression and discrimination and bullying might have played into that, like pulling them away from that process of getting to know themselves, really working to dismantle this internalized oppression. And then as providers, we can also think about how much we can do as a provider to create better healthcare experiences and address the healthcare disparities. So, one study was talking about how success in terms of patient care can be very dependent on a provider's knowledge, attitude, skills, and behaviors. I think these are some helpful questions to think about as a provide for the provider. Did they recognize the patient's individual strengths and challenges? Were they willing or able to alter how they communicate with patients? Were they open to changing their workflow to accommodate needs? Excuse me. And did they treat patients with respect? So, basic things that we should be offering to all of our patients, but even more so here where there could be potential biases, and thinking about that provider reciprocity, their willingness and ability to modify their own behavior to meet patient needs and treat them with respect. So, this is a very big thing that as providers we can be considering and thinking about is how can we meet the patient where they are? How can we really show up in a way that honors and supports them? This was a couple of recommendations of things to explore with clients. So, a lot of it is about taking your time to really hear people out, validate them, understand that there can be some sensitivity around this. There can be some internalized biases. There can be some fears and frustrations within themselves, and maybe even considering the context that they're in and how that may impact their comfort with approaching these things. Some things you can consider for a trans client suspecting autism or an autistic client suspecting that they're trans. And here's some more if you have a trans client that hasn't considered they may be autistic, or someone that is just beginning or hasn't considered they may be trans and autistic. So, a lot of it is about being supportive, being curious, normalizing experiences, um, noting maybe areas where there might be challenges or where you could bring in more supports or accommodations. And different considerations. Like one of these is how a professional diagnosis may or may not be useful. Um, and also helping people to connect. I mean, that's one of the biggest things the seeing is giving people spaces to connect to others in the community because you may have something that was noted is that someone who is um, living at this intersection, they may not feel comfortable in spaces that are just for autistic people or neurodivergent people, and they may not also not feel comfortable in spaces that are just for the LGBT plus community. Uh, but that spaces that really hold this intersection are going to be more validating and supportive. Ideas of accommodations, different supports for communication, thinking about how can we create a sensory space that is really supportive, giving people space and freedom to be neurodivergent, to let go of these neuronormativity expectations, space to really explore and practice, reclaim being their full selves. Um, The other consideration that was brought up was universal design, which is design that is really considering making the space most accessible for all or most populations as much as they can. So, how you're designing forms, protocols, communications, different environments to be welcoming and effective for people with a variety of executive functioning, sensory, and communication needs. Um, Accessible to a wide variety of sensory needs. Um, so one of the sort of concept of universal design is it's about making society more universally accessible and usable to all, and it assumes a range of human ability is ordinary and not special. So a lot of times what can happen when we're thinking about accessibility is we create an other option that sort of segregates people out. Like, okay, you have this characteristic or quality or identity, so you go over here, everybody else is over here, but you go over here and you do it this way, this other path. Versus how can we create a space that's really open to everybody, where everybody can do the thing, everybody can participate and engage. And that is another way that we can think about accessibility in a more inclusive way. So I also wanted to bring up, so I'm thinking about what accommodations might look like. One of the resources that we have is the Aspire Healthcare Toolkit. So this is made by the Academic Autistic Spectrum Partnership in Research and Education. So as I was mentioning before, unfortunately, a lot of autistic research is not done by or including autistic people. This website and organization, they actively, I don't know if some of the researchers are autistic. I don't know if all of them are, but they work collaboratively with autistic people to design their their toolkit and resources and research. And so this is could be a resource that you offer to your patients and look into as a healthcare provider. So this is what some of it might look like. So the patient will go in and they will answer, I believe, answer some questions and then be given and you will be given some recommendations, or they will get that document that they can share with you. So here we have some ideas for helping. This is an example of how you could help this patient with communication, recommendations to help the visit go smoothly, to comply, information that it can help you to better understand the patient. Here's some other things like information for office staff, what might be helpful for doing things like setting up an appointment, handling the weight and rooming and things like that. So that is something you could use. And this other side of the slide are some other patient forms and worksheets that also might be helpful for your patients. So I also pulled up these as some examples of accommodations. So this might be some common things that as a provider in this area, you might find helpful. So some ideas with physical exams, like warning the patient if you're going to be touching them, limiting the amount of time the patient is undressed, giving the patient some extra time to process things before they have to respond, thinking about phlebotomy, like if you're sending people to do blood work or having to take hormone shots. Like these are things that you can go through with your patient, or resources that you could offer them to sort of think through what actually, because again, like we've talked about, that can take some time to process and figure out like what actually works for me, what feels uncomfortable, because there may be so much trauma around uh, being taught you need to ignore your own needs or suppress your sensitivities to make other people uncomfortable, or to make other people comfortable. And so this is a way to really invite the patient to think about what actually works for them and sort of explore and that process. So I wanted to end off with the 10 principles of disability justice: intersectionality, leadership of those most impacted, anti-capitalist politic, commitment to cross-movement organizing, recognizing wholeness, sustainability, commitment to cross-disability solidarity, interdependence, collective access, and collective liberation. So hopefully, in whatever work we're doing, we are thinking about these principles and incorporating them into the work that we're doing. So there were a couple of questions that were asked uh, during this presentation, and I wanted to address a couple of them in case they are questions that come up for you. So I had several questions about assessment, and what I will say is that assessment is not my priority or focus. So there's better resources for assessments. Some of the things where people were sharing with some local resources to get assessments. And what I usually tell clients is to um, check in with the provider. How often are they working with people that have similar identities? as you, and what's their experience in terms of diagnosis and training with people that are living at your intersection of identities. And there are some assessments like the ADOS that is considered one of the gold standards and is also noted to often miss girls and women. So it's one that is talked about in that frame. And so if the provider's doing some of those assessments, what else are they putting in play to catch? And so that's something that I encourage clients to ask about. The other thing, as we brought up here, is sort of a consideration of what are the impacts of diagnosis when, because as much as we are working towards developing a progressive lens or neurodiversity lens, a paradigm on this, is that there is still a lot of discrimination around autism and uh, how might that impact the individual. And it's not that you should necessarily discourage them from getting diagnosed, but to actually talk about there is still a lot of fear around getting a formal diagnosis, like how that might impact if you were to want to move to another country, if you were to want to adopt children, if you were to want to do different things in life. And so it is something to sort of consider. With that being said, and what was brought up is that some people find it extremely validating. Unfortunately, with the underdiagnosis or misdiagnosis, some people find it very invalidating. And so that is the invitation, is to really actually talk through it with clients about their options and to weigh it out. One of the things that I brought up as a challenge with some of this, whether we're talking about identity or access to things like educational accommodations, is like, why does someone need a diagnosis to get those things? Why does someone need a diagnosis to feel valid in their identity? And how much is that tied to some of that internalized discrimination? Why do you need a test to show that you are who you are? And so that may be some therapeutic work uh, that you can explore to divest from the system of pathologizing and internalized oppression. And then also, why do we have educational systems that require diagnoses to um, accommodate students? Why are we not doing things like working on or another option may be to challenging systems to offer more universal design in terms of their structure. So for example, I have many clients that do have diagnoses and they get accommodations, and those accommodations aren't actually what would be helpful or supportive to them. So it doesn't actually necessarily guarantee that someone would get a supportive educational environment simply because they do get some type of accommodation. So these are just, so this presentation is more inviting into a different way of thinking about things than um, what I thought it was interesting that so many questions were coming up about assessment when I was part of this presentation is really to invite into thinking about these things in a different way, which is less about it being a diagnosis and a pathology and more about creating a world that's more inclusive of people. The other question that I recall being asked was by someone who was designing a group for individuals in this living at this intersection, and if there's anything that they could do regarding the slow processing. And I scanned my brain at the time and couldn't think, because there weren't any. The one group research study that I saw was more so for youth and more about gender exploration than and that wasn't really necessarily as applicable. And I wish that I had thought of let's challenge the idea of slow processing speed. Why do we think that autistic people have slow processing speed? And this is something that, again, we're inviting in a new way of looking at this. And there's a couple of things that came up. Is one is something that can happen with autism is with sensory overload. So there's less filtering. So stuff is hitting you more strongly, more intensely, sometimes sensory wise. And so are there things that you can do to work with that in your space so that there is not as much of an intense sensory experience, for example? So that is something you could consider is how can I create a space that's really sensory affirming to people, that is supportive, that is validating? The other thing I thought of was, and I'm saying all this not as a group expert, I'm not a group expert. So these were just some ideas that I had, is challenging the whole group process idea, like even challenging the structure of how groups are supposed to be. And I thought of this idea that, one of the things that autistic youth and adults are challenged with is like, oh, you don't care, or you're not empathetic, or you're not engaging because we're sitting in a room and you're like doing something else. You're not like talking to me and interacting with me as much. And how some autistic people find it very comforting to just be in a room with people and doing separate activities. Like, this is how we play together. And so I thought about that idea of like, what if we deconstruct the structure of what group therapy is supposed to be and open the door for people to be doing all different kinds of things in the space, doing their own thing? Maybe some people are sitting in the corner drawing. Maybe some people are are gaming together, or different. Maybe some people are talking, but that you open up the space to be flexible, to play with different ideas of what might feel supportive to them, and it may not be the standard neurotypical thing. The other thing that I thought of was this idea that related to stemming. So, stemming is often talked about these repetitive movements that autistic people sometimes do, and that it is a nervous system processing strategy, that it is a release of energy, of tension, and that's why things like ABA can be so harmful because they're teaching people to not do that. And so, where does that energy go? How does that thing get processed? And when it said that that piece about neuronal differences, I've heard it described as like, in terms of brain development, if you think about babies when they um, and again, this is just what I read somewhere, but that like how they have these like sort of jerky movements, and that is their brain processing and working through different experiences, interactions, processes. And over time, for neurotypical people, that gets kind of pruned off. And I don't know all the neuroscience to be able to talk about all the differences, but that trajectory of development is different for autistic people. And so, what this autistic researcher was talking about is there may be so much more there. Like, to even say that it is just a nervous system processing thing is so limited. Like, this and stemming and movement, there may be so much opportunity for creativity and understanding of humanity and complexity, and that if you are in a group process, um, how beautiful could it be to give someone space to reclaim their stimming in a supportive space, but also to express themselves through that if they felt safe enough? And what kind of possibility that could be to really give people support for not having to communicate with words in a way or with speaking. Um, and as part of your group process. So if you're looking at these different pieces, again, it may not be that they're slow processing. It may be that there's some kind of discriminatory thing going on in terms of the expectations. Like we're not really creating an accommodating or supportive space as much as we think we are. So there's different layers maybe of exploring accommodation where you're like, yes, I support you. I'm good with you. And then opening the door to move into what kind of creative possibility there may be when we really move towards liberation and justice. So, those are just a couple of thoughts that I wanted to add in from some of the questions I received. And the next pages, I have 5 pages of references. And here's some of my contact information, my email address, my websites, and of course, this YouTube channel. Thank you for joining me today. I hope this was helpful and informative. I will say that I am not an expert in this area. This is an area of interest. It's an area of passion in terms of my own self-understanding and work and the clients that I'm working with in my community. And I hope that this was helpful and supportive information as we continue to grow and learn from autistic people and neurodivergent people of what is, and trans people, of what is helpful and supportive to them in creating a better, more inclusive world. Thank you.